All right. Good evening and welcome to today's discussion. If you're just joining, this is what we are going to be discussing today. Um, Basically, you get an overview of what the contents of the course. If you have not been studying, I would suggest that you go back and start your studies. Okay. So I'll take you through the outline so that you understand what it looks like. So this is the curriculum. Within the curriculum, there are 14 sections with 158 lessons. Okay, so you have anatomy. Each one has, like you can see, anatomy has 17 lessons, physiology 29 lessons, biochemistry 15, genetics 9, microbiology 11, pathology 9, pharmacology 13, emergency medicine 9, core medicine 15, psychiatry 10 topics, dermatology 4, biostatistics 6. Now, as you keep scrolling down, you will now see the package, the section that has the 500 past MCQs, answers, and explanations. Okay, so there you see still subdivided into subjects. So anatomy and embryology, physiology, pharmacology, microbiology, immunology, genetics, biochemistry, dermatology, psychiatry, geriatrics, clinical medicine 1, 2, and 3. Then 2023, 2024 MCQs. Okay. Then let's say you are just confused, you want to know what the entire outline is. Okay, so based on previous exams, we're able to make out list of topics that we call essential topics outline. Okay, so these are topics that have been recurring in exams. All right. So if you click on that, if you click on that, you'll see what we call the essential topics outline. Uh, so these are like still like the ones that we already looked at above, but this one is just like the topics alone. So you can still decide to scroll through them to understand what you are meant to know. You want to go for this exam, you want to go for an exam, you need to know what you're supposed to know, right? So these are topics that questions have been repeated from over and over and over again. All right. So
Abíọ́lá ó pe gbogbo tí ó jẹ́
please mute your
dead
mic.
ó pe kó pe
If I tell you to move your mic again, I'll remove you. Okay, so like I was saying, so these are the topics. So you are supposed to, as a candidate that is going for an exam, you're supposed to go through the outline. Different people have methods they usually apply. Some people prefer to read first, like finish the outline, then they now go through the MCQs. Some people prefer to start with the MCQs, though me, usually I suggest candidates go through MCQs, right? So when you go through an MCQ, it gives you an idea of what is expected of you to know. So each question that you go through, you now have an idea. Then you can now study you know, the topic that is related to that question, right? So that could be a way to go through questions. So something like that. Once you do it that way, you get to cover. So I want to believe that everyone here at least have found a way to um, go through the topics and consolidate their knowledge. Okay. What I hope to achieve today or in our sessions will just be to um, talk about some of the questions, okay, and how we are going to approach them. I'm going to be sharing something called the whiteboard. And when you see the whiteboard, don't write on it. Okay, I'll be the only one writing on it so that um, it will be easy to for you to appreciate later. Then when I select a question, I'm going to also post it in the chat. This is the chart here. So make sure you are there. That's where you post your answers when I post a question. I hope you guys can see the screen.
No, we can't see the screen. No.
Huh?
I can see the whiteboard.
What was the other person saying? Okay, so that's the question, the first question there in the chat. Which of the following is incorrectly I said don't move it, Dr. Ugo. Dr. Ugo, I said don't move it when I post it. Don't touch it. Just go to the chat and interact with the question in the chat. Attempt it in the chat, okay? Don't move the one on the whiteboard. Don't touch it. Okay. Which of the following is incorrectly matched? Friedreich's ataxia, that's autosomal dominant, sickle cell disease, autosomal recessive, hemophilia A, X-linked, von Willebrand and syndrome, autosomal dominant. Write your answer in the chat. Attempt the question. Who is this person now? I'll remove you, Dr. Ugo. You are scattering the screen. See what you are doing.
Papa, Papa, stop. You come to tablet.
I'm so sorry. I was trying to maneuver the stuff. I'm sorry.
Or shall it if you shall it couple? Okay.
Type in the chat. Type your attempt the question. When the question is posted, everybody should attempt so that we can move fast. Okay, so yeah, so usually when I ask a question, I take that as an opportunity for you to also learn more about the topic of this course. Okay, so let's go to genetics. So if you want to learn more about this particular topic, if you go to genetic, you can see my screen, right? If you go to genetic disorders, right? Dr. Ben, mute your mic. Your mic is
Okay.
distracting. So if you go to under genetics, right? If you go to, you can see the topics under genetics. All of them are very important. DNA, chromosomes, genes and traits, DNA versus RNA, coding and non-coding sequence. Please mute your mics. Mute your mics. Who is this person without a name? So, DNA, RNA, coding versus non-coding DNA, genetic code, human genome projects, genetic disorders, okay, cancer genes. That's where you talk about oncogenes, proto-oncogenes, and things like that. Genetic engineering, right? So if you go to genetic disorders, that's where you will get to learn more about things related to autosomal recessive, autosomal dominant, X-linked. Because if you talk about genes or genetic disorders, you could have uh, autosomal disorders, right? Which means they are in the other chromosomes apart from X, right? So X and Y chromosomes are called sex-linked chromosomes, okay, or sex chromosomes, right? So if there are disorders that are in the sex chromosomes, they are called sex-linked diseases, right? Then if the disorders are in any other chromosome apart from these X and Y chromosomes, they are referred to as autosomal because these other chromosomes control every other thing in the body from the height to the color of the eyes to everything, right? Genetic diseases and all that. But the X and Y chromosomes are called sex chromosomes and they control everything about the sex, male and female sex, and all this stuff, right? So it's been found that most diseases, most genetic disorders are going to be either sex linked or autosomal. Now, if they are autosomal, they could be recessive. You know your Mendelian genetics, where they talked about recessive disorders, which are disorders that require two copies, okay, for the gene to be expressed, because there's a difference between a gene being present and the gene being expressed, which means that the characteristic in the gene is now being converted, right, into proteins and then being carried on so that it now becomes a physical attribute, right? So it's being expressed. So for that gene to be expressed, it means it needs two copies of that same gene. For example, what will I use as an example? Okay, yeah. For example, sickle cell disease, which is like the popular one, based on the fact that it's being tested in premarital counseling, right? So you need two copies. It means the partner has to have a copy, and then the other partner, each partner has to have a copy for sickle cell disease to express itself. If they pass on those two copies, right? Each person brings a copy, the other one brings a copy, and they pass it on to the offspring. Uh, the offspring can now express the disease, right? But in autosomal dominant, that's in dominant disease, it means just the presence of one copy is enough to express that gene, right? Something like, you know, neurofibromatosis, right? Once one partner has it, the other partner doesn't need to have it for that child to have it, right? So those are the, the basic understanding of your genetic disorders. So the general thing to note is that most autosomal recessive disorders are biochemical disorders or enzymatic disorders, right? So which means that they have to do with things like you know, enzyme deficiencies and things like that, right? Most autosomal recessive disorders. Okay, there are still exceptions, but most of them fall into this broad generalization. Then the most autosomal dominant disorders are structural disorders, right? Which means that most of them has to do with you know large structures, large proteins in the body. So things that are gross, things that you can see physically. So something like neurofibromatosis, they have this cafe au lait spots, something like all this gene, what do they call these guys? This dwarfism, in quotes, dwarfism gene. That's also autosomal dominant. There was a case that was trending recently on social media where a dwarf or a man that was had that short stature got married to a lady that's in quotes doesn't have the short stature, and they gave birth to an offspring, and the offspring has the short stature, right? And the reason is that that gene for short stature is autosomal dominant. So there is anywhere it shows up, it's going to dominate. And so that's the issue. It doesn't matter whether the other partner doesn't have it, it will show up always. So that's what autosomal dominant means. Then for the X-linked disorders, most X-linked disorders are X-linked recessive. Okay, so just very few diseases are X-linked dominant. Very few. Okay, you can count them on your fingers, but most X-linked disorders are um, X-linked recessive. So things like this hemophilia, color-related color blindness, things like that are X-linked, and things like although GCSPD is an enzyme disorder, but it's a it's an exception. Okay, it's an enzyme disorder, but it's also X-linked recessive disease. So these are some of the things you need to know. When you now study, you will now be able to have a longer view. For example, there are mnemonics that you should look out for. There is this one, AEIOU, that's the vowels of the body. I mean, the vowels of the English language, right? A, E, I O U. This one is used for like autosomal recessive disorders. So when you look at them, you find out what they mean. Then for autosomal dominant, they use very dominant uh, humans, something like that. So there's a way you are going to fit in all the, if you like using mnemonics, there's a way you're going to fit in all the autosomal dominant disorders into these mnemonics. Very dominant humans. So by the time you write them out, you see that they are following those alphabets. So that's basically that about it. That 8-year-old woman with 3-year history of weight loss, increased appetite, and neck swelling has a 2-day history of restlessness. She has been on carbimazole. Her blood pressure is 160/90, and her pulse is 140 beats per minute. What's the appropriate next line of management? Dr. Musti, move your cursor. You are blocking the question, the options for other candidates. And so I agree with you on the propranolol being the answer, right? Because um, you can see the pulse, you can see the blood pressure. So in this situation, you are most concerned about the adrenergic effects, adrenergic effects of the hyperthyroidism. Okay, so you want to manage that first, then you now continue with anti-thyroid medications like carbimazole, metimazole, proprietary uracil, right? Usually, there's another version of this question where they also talk about like a pregnant woman. Uh, so, if a patient is pregnant, you also want to stabilize her, especially if like her, if there are signs of hemodynamic inconsistency, right? So you have high blood pressure, you have high pulse or something like tachycardia, you can give a beta blocker, right, to normalize it. And also in pregnant patients, ideally, uh, for most patients, you're supposed to use carbimazole and metimazole, right, as the major anti-thyroid medication, right? But in pregnant women, in the first trimester, you don't use carbimazole and metimazole because it's contraindicated. It can be teratogenic in that period of organogenesis, which is the first trimester, right? The first 8 weeks. So you avoid it. You use propylthiouracil in the first trimester, okay, of pregnancy. But the risk with propylthiouracil is that it has hepatotoxic effects. So you're also not going to use it for a very long time. So if you use it within that first trimester, after the first trimester, you also switch back to carbimazole, metimazole. So what it means is that if a patient is hyperthyroid and the patient is about to get pregnant, you're supposed to be part of the management plan to prepare for it. Okay. So the next question, 25-year-old female with a chief complaint of severe headache. Described as the worst headache of her life. She has nuchal rigidity, photophobia. CT scan reveals subarachnoid hemorrhage. Which of the following is the most appropriate immediate management? We have nimodipine, IV fluids, IV antibiotics, urgent neurosurgical intervention. So first of all, you have to make a diagnosis. What's the diagnosis for this patient? What's the diagnosis, doctors? Why is everybody quiet? What's the diagnosis? You guys don't know the diagnosis. It's the only two persons that are in this chat. Dr. Ben, what's the diagnosis? Of course, it's subarachnoid hemorrhage. Anywhere you see someone talking about they had the worst headache of their life. Okay. Whenever you see mention of worst headache of their life, most times it's subarachnoid hemorrhage. And they already told you that the CT scan is not even like something you're supposed to even be guessing because they said it in the question. But like even if they didn't say it in the question, once you see the worst headache of her life, that's most likely a subarachnoid hemorrhage. It's most common in females. It's a severe thunderclap headache. Thunderclap, like sudden thunderclap, severe headache, referred to as the worst headache of the life. And usually the headache is worse on the back of the head, okay, just in the posterior, the occipital area, right? That's usually where the headache is. And it's associated with signs of meningeal irritation. The only difference between this and something like meningitis is that In meningitis, one is not the worst. Meningitis will just be gradual getting worse. It's not the worst headache of their life. And two is that there's no suddenness to it, and also there's no fever. Though subarachnoid hemorrhage sometimes may also have fever, but like um, some of these things are the differentiators. Okay, so usually you treat them with IV. You can give them IV fluids because it's also part of the management. But the most appropriate that you are going to actually give would be an oral nimodipine. Okay, because that's like the drug of choice to reduce vasospasm in that blood vessels. Okay. 40-year-old man presents with epigastric pain, radiating to the back, jaundice and vomiting. His urine is dark. Which of the following initial investigations is most appropriate? Serum lipase, abdominal ultrasound scan, liver function tests, upper GI endoscopy. When you see a question that is painting clinical picture, the first thing that should come to your mind is what's the possible diagnosis. You think of the differential diagnosis. In the abdomen, when there is a pain anywhere, they are usually differentials, and then you now zoom in on one of the differentials as the diagnosis, and that when you make that diagnosis, that will now help you to determine what investigation you are going to use. Remember, they're asking for initial investigations. What's the diagnosis, guys? Are you asking me? Are you asking me or are you answering? You have to be confident of your answer. You're a doctor. So if a patient comes to you, will you be asking the patient, do you have pancreatitis? State your answer with confidence. If you don't get it, you don't get it. And if you get it, you get it. That's it. When you see pain in the epigastric region, you see a patient, this is your abdomen, isn't this the abdomen that is usually divided into 9 sections? Is it not? You did your anatomy, you know where each of the organs are in this abdomen. Uh-huh. So when you're seeing right hypochondrial, left hypochondrial pain, when you're seeing right, okay, you should know, have an idea of what could be going on. When you're seeing epigastric pain, left hypochondrial pain, when you're seeing you know, pain in the middle, like umbilical area, right? When you're seeing lumbar, right lumbar, you should have an idea of what's going on. When you're seeing left lumbar, you should have an idea of what's going on. When you're seeing left iliac fossa, you should have an idea of what's going on there. When you see a pain in the right iliac fossa, it should give you an idea of what could be going on with the patient. When you see a pain in the hypogastric area, you should also have an idea. So this is like the general view of the abdomen. So in the epigastric region, when you see pain there, most of you will think of peptic ulcer disease, right? Because that's a common thing. But also a pain that is radiating to the back. Peptic ulcer can also radiate to the back. But peptic ulcer will not give you features that suggest that there is an involvement with the pancreas or the bile. Okay, when you are seeing jaundice, it's telling you there could be an involvement with bile ducts and things like that. And the only organ that has an involvement with the bile ducts, okay, is the pancreas, because the bile duct, as it's coming down from the liver, is going to join with the pancreatic duct, and both of them will join together and enter into the second part of the duodenum through the ampulla of Vata, right? So you know that there's an association between the pancreas and the bile duct, and that tells you that if there's an inflammation of the pancreas, there's going to be um, affectation or obstruction of the bile duct, which will now lead to, because what you are seeing there is an obstructive picture. Once you see dark urine is dark, stool is pale, that's an obstructive picture of jaundice, right? So the only thing that will give that kind of obstructive picture is when there's something that is involved. And then with that back pain, epigastric pain that is radiating to the back, okay, these are just the few distinct that you have, okay? Peptic ulcer will not cause something. It can cause epigastric pain radiating to the back, but not jaundice and dark urine and things like that. Usually not you know, presentation. If there is perforated peptic ulcer, which is a complicated peptic ulcer, what you have is generalized abdominal pain. Initially, it will be in the epigastric region. Then, when it perforates, it will now become a generalized abdominal pain with rigidity and all those signs of um, peritonitis, right? Will now be there, and then there will now be systemic features and things like that. Okay, so. And then if a patient has pancreatitis, what you'll be going in for is not liver function tests. Upper GI endoscopy will be more for peptic ulcer. Abdominal ultrasound will be more for liver disease. You will still do abdominal ultrasound for pancreatitis, but initial investigation, serum lipase is very sensitive to, it's a sensitive test for pancreatitis. So that's what you will do first. Remember that enzymes are being produced by the pancreas. So digestive enzymes, and lipase is one of the enzymes that is being produced by the pancreas, which is supposed to help in the digestion of fats. So it means if it's now present in the serum in large quantities, it means it's leaking. It's not going where it's supposed to go. It's supposed to get to the GI. But if there's pancreatitis, it's going to be leaking into the bloodstream, leaking all over the places, right? So Patient presents with history of recurrent painful and disabling headaches, often accompanied by nausea and vomiting. These headaches are episodic and occur several times a year. Which of the following diagnosis text is most likely to be useful in evaluating this patient's condition? We have ECG, MRI, LP, blood tests. Well, based on this clinical picture, what do you think could be the diagnosis for this patient? The most likely diagnosis, because that will help you to determine to know what you're doing. Let's think now. What's the diagnosis? What do you guys think? So, like you're in the clinic, the patient comes to you with something like this: recurrent painful headaches, nausea associated with nausea and vomiting, episodic, occurs several times a year. Most times it's migraine. It's migraine. This is like classical migraine. Okay. Episodic. ICSOR will always be present. It will be constant. It will always be present. It will not be episodic. Right. Though ICSOR can be made worse by things like bending down or something like that in the morning and things like that. Well, it will always be constant. But when something is episodic, it comes and goes. It comes, then it goes. Right. So migraine should be the top of your mind, and you don't need an MRI to make a diagnosis of migraine. So you're just doing those blood tests just to rule out maybe autoimmune disease or anything that could be going on, maybe an infection or something, right? Before you get to MRI, you must have done so many other um, tests, right? So we'll go for option D. So 28-year-old woman presents with a history of fatigue, weight gain, cold intolerance, and constipation. Reports feeling unusually cold, even in warm environments. Okay, this symptom is called something. So physical examination reveals slightly puffy face. Which of the following is the most likely diagnosis? Of course, this one is baby question, right? Is there anybody here that is not sure of the answer of this question? one of the easiest topics is hyperthyroidism and hypothyroidism, because their symptoms are basically opposites of each other, right? So if you know hyperthyroidism symptoms, you already know automatically the symptoms of hypothyroidism, because when you reverse it, you get the other one. So the way they are mentioning cold intolerance, you have hot heat intolerance in hyperthyroidism, you have weight loss, you have hyperphagia, you have uh, hyper defecation. Instead of constipation, you have hyper defecation, like diarrhea. Okay. Patient presents with a sudden onset of severe unilateral facial pain accompanied by tearing and redness of the eyes. Which of the following is the most likely diagnosis? Bell's palsy, trigeminal neuralgia, cluster headache, migraine with aura. So the options are actually very close differentials. The options are actually very close differentials, but I think the giveaway here is that it's a facial pain, not a headache, right? Cluster headache means it's a headache, right? But cluster headache can also be associated with tearing, redness of the eyes, things like that. Um, Bell's palsy can cause unilateral facial weakness or paresis, right? But there will be no pain in Bell's palsy. It should just be facial weakness. So it's a lower motor neuron lesion, right? Then trigeminal neuralgia, there is that burning uh, pain on one side of the face. So it's a facial pain. And it can also be associated with that eye redness and then tearing. So, um, but cluster headache is a very close differential. But I think the giveaway here is that facial pain, not headache. So 65-year-old male presents with a history of progressive weakness in his proximal muscles, difficulty climbing stairs, and a recent onset of proximal muscle pain. It denies any fever or recent infections. Which of the following is most likely diagnosis? progressive proximal myopathy. No fever, no recent infections, difficult climbing steps. Yeah, looks like. Which popular person had ALS for a long time until their death? You people don't know about Stephen Hawking, so what? One thing is that as a doctor, you need to also like, apart from reading your medical stuff, you also need to broaden your view, because other things that you learn also help you. You'll be able to relate what you are learning much better, because you relate them to real life, not just it's not John F. Kennedy, it's Stephen Hawking. Yeah. So you'll be able to relate what you are reading that may look abstract to real life, because that's the way your memory works. You need to relate, you know, abstract. You need to make things real for you to be able to relate with it better. For example, you're able to, some of you can remember the names of footballers because you are you watch this football, it's real to you, you discuss it, you are talking about it with your friends, you are laughing about it, you drink beer with it. So that's the same way. If you can relate what you're studying with real life events, or real life people, or real life things that you noticed in your environment, it will help you to get the knowledge to stick much better, right? So now, though in this case, amyotrophic lateral sclerosis is not the answer. uh, okay, because of the when you see proximal muscle affectation, difficulty with climbing steps, usually this uh, ALS is progressive and kind of starts from the down and keeps going up, right? It's like, so it starts from the distal going up. But when you have proximal muscles primarily affected, that's most likely polymyositis. Okay. So 30-year-old female presents with a history of recurrent painful red swollen joints, primarily affecting the wrists and ankles. She also reports fatigue and low-grade fever. Which of the following is the most likely diagnosis? Osteoarthritis, rheumatoid arthritis, gout, and septic arthritis. Each of the arthritis have somewhere where they localize to, right? So when you're seeing um, an arthritis, it should give you an idea of what it's most likely. When you're seeing involvement of the wrists, you know, the small joints of the fingers and things like that, that will point you more towards rheumatoid arthritis. Osteoarthritis is usually localized in the large joints like the knee joint, hip joint, things like that. Okay. Then septic arthritis also localizes to the knee joint and hips, large joint as well. Gout usually localizes to the toe, the big toe. Okay, that's big toe. That's where it gets to most times. So it's rheumatoid arthritis. And rheumatoid arthritis can also present with systemic features. Remember, it's like an autoimmune disease. So just like SLE, it can present with systemic features.